Welcome all of you. Welcome to our pharmacology session brought to you by Unacademy. Today we will be discussing a very important topic, and that will be drugs for angina. Drugs for angina. We will discuss the last minute the revision MCQ, the last minute revision points. I'm your pharmacology educator, Dr. Arpit Agarwal, and let's crack it. Brief introduction about myself. I am your pharmacology educator, Dr. Arpit Agarwal. I've been teaching for over 10 years now, both within India and abroad. Over all these years, I have successfully mentored more than 50,000 students preparing for pre-PG as well as for the FMG screening examinations. If you are visiting the Let's Crack NEET PG channel for the first time, and if you have not yet downloaded the Unacademy app, I suggest you do it right away. Type Unacademy on the Play Store, download the Unacademy Learning app. It is the best learning app currently available. It has various segments, NEET PG, FMG, and you can enroll according to your requirement. In any segment, you'll find the best educators of the country. We have the Plus subscription, which gives you unlimited access to live classes, live tests from the top educators, several specifically designed batches to suit the requirements of NEET PG students, FMG students. We even have specific batches for INI CT as well as the next examination. You can also go for the Iconic subscription, which gives you unlimited live classes from an academy, plus also provides the recorded video lectures from the prep reader. So you'll get the best of the two learning platforms, Unacademy plus prep reader. So it's an iconic in nature really. There is no such offer in the market as of this. As I said, with the subscription comes the access to the best specifically designed plus courses. So one of them which has recently started is the INI CET 24-day MCQ marathon. So INI CET is around the corner, going to happen in May, and we have the revision batch already going on, which consists of 19 subject-wise tests and grand test with the best educators. Similarly, you have a FMG specific revision batch, FMG test and analysis, which has also recently started. It consists of 9 subject-wise tests, grand test, high-yield topics, and PDF and recorded sessions are also available. Needless to say again, best of educators across the subjects will be taking care of your needs. Now, once you download the Unacademy app, use the code Dr. Arpit Agarwal. You can use this code and you will be able to unlock the free classes by this particular code. So use this code to unlock the free classes. Watch these free classes and then decide whether you want to go for the Plus or the Iconic subscription. Both Plus and Iconic subscription can be availed in a varying duration, as you can see. If you have less time, go for short duration. If you have longer time, you can go for the longer duration. The code will also give you a 10% discount. This is the schedule for our ongoing last minute pharmacology, last minute revision MCQ. This series we have been doing since 6th of April on your favorite YouTube channel, Let's Crack NEET PG. This is the name of the YouTube channel where these last minute revision MCQ series is going on. We started on 6th of April and today on 10th of April we are going to first discuss drugs for angina, and this will be followed at 10 p.m. by drugs for arrhythmia. Okay, so very structured, very specific, short, crisp sessions with the most important last minute revision MCQ in the latest format. So today we have drugs for angina, and the first question on your screen, what is true about benefit of nitroglycerin in angina? So nitroglycerin is used in angina, all of us know. The question says which of these is true? So as you can see, the latest pattern MCQ, multiple choice answers, multiple correct answers can be there. Let's look at these statements one by one. Nitroglycerin mitigates, that means reduces angina by increasing total coronary flow. This statement is a false statement. Please remember, this is a false statement. Nitrates do not increase total coronary blood flow. What they cause is known as redistribution. They cause redistribution of coronary blood. That is what they cause. They do not increase the total blood flow in coronary. They redistribute it to ischemic areas. So first statement is false. It mainly decreases the afterload. Afterload is decreased by drugs that are arteriolar dilator. Arteriolar dilation decreases after load, but nitrates we know are venodilator, so this is also false statement. Nitrates are not arteriolar, they are venodilator and therefore they decrease. Nitrates decrease mainly preload. Preload. Those drugs which are arteriolar dilator, those drugs decrease after load. Nitrates decrease preload. So second statement is also false. They increase left ventricular end diastolic pressure. End diastolic pressure is going to be reduced by nitrates. Because nitrates decrease preload, they will decrease the blood coming into heart, and that is why they will decrease the end diastolic volume and pressure. So third statement is also false. Nitrates dilate capacitance vessels. This is a true statement. Veins are known as capacitance vessels and nitrates are venodilator. So they will dilate capacitance vessels. Remember, arterioles are known as resistance vessel and veins are capacitance because their veins are large, they have large capacity. So they are known as capacitance vessels and these veins are dilated by nitrates. So this is true. Decreasing the size of the heart, as we have already written, by dilating veins, they decrease preload, that decreases end diastolic volume. So size of the heart or ventricle decreases. So this is also true. So true about benefit of nitrate is 4 and 5 and option number D. And Avinash, Sayantan, Prabhakar. All three are correct to answer. The correct answer is option number D. So I hope everybody has enjoyed this question. Whatever you want to know about mechanism of nitrate is described. You can check any question from any year about nitrate mechanism. These are the 5 things that they asked. So now you should know they do not increase total coronary blood. They do not decrease afterload and nitrates do not increase end diastolic volume or pressure. Okay, so that should be borne in mind. Next question. Nitrates used for all conditions except. So which of the condition nitrates are not used? Not used. Okay. So please I request everyone, सभी participate करें, सभी अपना आंसर बताएं. Nitrates used for all condition except. Which one is not a use of nitrates? And everyone, not just Prabhakar, Sayantan or Avinash, everyone come up with your answer. CHF, cyanide poisoning, esophageal spasm, biliary colic, methemoglobinemia. Nitrates are used for all except. So let's take one by one. Congestive heart failure. If there is acute congestive heart failure, we can give IV infusion of nitroglycerin. So it can be given. Especially if that CHF or heart failure, systolic failure is caused by acute MI. So when there is acute MI, patient can develop systolic failure, we give IV nitroglycerin. Cyanide poisoning, we give nitrates in cyanide poisoning, that is true. But nowadays if somebody asks what is drug of choice for cyanide poisoning, then please remember nowadays drug of choice is hydroxycobalamine. Nitrates can be used, but now they are not drug of choice. But nitrates are used along with sodium thiosulfate. These are the two: esophageal spasm and biliary colic. Nitrates relax the smooth muscles of esophagus as well as the bile duct. So they can be used for lower esophageal spasm or biliary colic. Methemoglobinemia, please remember, is a side effect of nitrates, not a use. So what happens when you give nitrate? The hemoglobin which has ferrous nitrates oxidize this hemoglobin. This is a side effect of nitrate, and now we have development of meth hemoglobin which has oxidized iron in the form of ferric. So this is a side effect of nitrate, not a use. And if you want to treat or bring back this meth hemoglobin to normal hemoglobin, you need a reducing agent, and that you should know is methylene blue. So methylene blue is sometimes asked as antidote of nitrate toxicity. So what will you do in nitrate toxicity? You will give methylene blue to convert hemoglobin back into methemoglobin back into hemoglobin. So nitrates cause as a side effect methemoglobinemia. That is not a use. So option E is the answer. Nitrates are used for all other A to D, but not for methemoglobinemia. What is methemoglobin? Ferrous oxidized to ferric. This is caused by nitrates and treated by methylene blue. Next question. Concomitant administration of this drug with nitrates is contraindicated due to marked hypotension. So what is that drug which should never be given with the nitrates? Nitrate should never be given with this drug, because if you give, it causes marked fall in BP. Severe hypotension occurs. Which is that drug? This is a very commonly asked question. And correct answer, yes, Sayantan, is option number D, sildenafil. Yes, Prabhakar, you are also absolutely correct. That is the correct answer. So sildenafil, which is a phosphodiesterase 5 inhibitor, should never be combined with nitrates. What happens? Nitrates increase cyclic GMP by releasing nitric oxide, and cyclic GMP is going to cause vasodilation. Now what happens? That cyclic GMP is broken down by the enzyme known as phosphodiesterase. So if you inhibit this particular enzyme by giving the drug sildenafil, which is a phosphodiesterase inhibitor, so when phosphodiesterase is inhibited, level of cyclic GMP will go very high, and therefore excessive vasodilation will occur, and that will cause excessive fall in BP. So never give phosphodiesterase inhibitor with nitrates, because it will cause excessive fall in BP. So sildenafil and nitrate should be separated at least by 12 hours. At least 12-hour difference has to be there between nitrate administration and Viagra administration. Next question. A patient with angina is refractory to combination therapy with a beta blocker, a nitrate and calcium channel blocker. So patient cannot be controlled on this combination therapy. Which drug may be useful in this particular patient? So obviously we are looking for an add-on drug. Beta blocker, nitrate, calcium channel blockers are not able to control this patient. Which drug you will add out of the options that are provided? Aspirin, heparin, statin, ranolazine. Yes, so correct. Ranolazine is the correct answer. So ranolazine, we will see, is a new anti-anginal drug. It is a late sodium channel blocker. By blocking sodium channel, it will eventually decrease calcium inside the cell, and that will decrease the work of the heart. And therefore oxygen demand. Ranolazine, please remember, is an add-on drug. It is an add-on drug for chronic angina, not for acute angina, long-term treatment of angina. And the main side effect of ranolazine that you will remember, it has the potential to cause increase in QT interval. So these are the three things you need to know about ranolazine. Late sodium channel blocker, add-on drug for chronic angina, and main problem is QT prolongation. This can be added, as the name suggests, add-on drug, so it will be added to ongoing anti-anginal therapy. That brings us to another new pattern question, match the column. So we have some anti-anginal, newer anti-anginal 1, 2, 3, 4 given, and you have to match with their mechanism of action on the right side. So Prabhakar, I'll answer your question. Okay, I'll answer your question, ranolazine. But let's first match ranolazine. I have already told you it is a late sodium channel blocker. So one goes with A. Trimetazidine is a metabolic modulator, inhibits fatty acid oxidation in heart. 2 goes with B. Ivabradine is a funny current or the sodium current blocker in SA node, not in other parts. In SA node, it is a funny current or late sodium channel blocker. So 3 goes with C. And nicorandil is a potassium channel blocker. Please also remember it also has the ability to release nitric oxide. So 4 goes with D. So A, B, C, D is the answer, and I believe option number B. Option number B is the correct answer. Option number B. Nicorandil. One peculiar side effect of nicorandil that can be asked is it can cause very large mouth ulcer, aphthous ulcer. Large mouth ulcers are quite common with nicorandil. One side effect that is commonly asked of ivabradine is known as luminous effect or luminous phenomena. It also blocks the sodium current, funny current in retina, and that causes excessive brightness. Vision becomes excessive bright due to funny current blockade in retina. So everything appears very bright. Now coming to the mechanism which you asked of ranolazine. Okay, so let's see this ranolazine. So please remember, consider this as a cardiac cell. Consider this as a cardiac cell. On this cell, please consider this as a sodium channel. So what is this? This is what we are writing as a late sodium channel. Late sodium channel. What is this channel doing? What is this channel doing? This is allowing entry of sodium inside the cell. Late because it opens late in the action potential. Now what we are saying that this channel will be blocked by ranolazine. That is what is ranolazine doing. Correct? Ranolazine is blocking a sodium channel. So now as you will understand, when sodium channel is blocked, there will be what? It will lead to decreased intracellular sodium. So inside the cardiac cell, sodium will be less because the sodium channel has been blocked. Now comes into picture another channel which is also present on heart, and that is the sodium calcium exchanger. Sodium calcium exchanger. As you can see, it is an antiporter bringing sodium in and throwing calcium out. So if sodium decreases due to any reason in the cardiac cell, then what will happen? It will increase the sodium calcium exchanger. Because sodium is low, so heart will try to bring in sodium by this another channel, and therefore it will cause increased expulsion or outside movement of calcium. So I hope now it is clear to all of you that calcium will be thrown out to make up for the less sodium. So that is what we have written. Ranolazine is a late sodium channel blocker. and ultimately it will decrease. It will decrease, I will write here, it will decrease what? Intracellular calcium. So give me a thumbs up if this mechanism is clear to you. The moment calcium decreases, there will be decreased intensity of contraction, that will decrease the work of heart and that will decrease the oxygen demand. So I hope now this mechanism should be clear, although nobody is going to ask, but at least if you are a good student, you will try to understand things. So that is what is the mechanism of ranolazine. Okay, so that is what you have to remember. So mechanism of ranolazine, I believe, is clear. If you want to, if you are able to remember it, very good. Otherwise, no problem. Okay, this we had done. Coming to next question. This combination of anti-anginal drug should be avoided. This is again a very frequently asked question. This combination should be avoided to prevent adverse drug interaction. So thank you Dr. Sayantan, Dr. Prabhakar, Dr. Avinash. So I hope you will encourage your friends, juniors, seniors to also join our ongoing rapid revision series on YouTube and also share this video. If you like this video, please hit the like button and share with your friends. Please do not forget to do that. Please share with your friends or in your college Telegram or WhatsApp groups. So what should be the answer? So we will avoid, basically, we will avoid beta blocker with verapamil. Beta blocker and verapamil both are cardiodepressant, both are going to decrease or block cardiac conduction. So if you give both of them together, then you are likely to cause heart block. Both are cardiodepressant, they decrease conduction. So if you give verapamil with beta blocker, heart block is a likely possibility. So avoid this, avoid this. On the other hand, DHPs, dihydropyridines like amlodipine, DHPs in general cause reflex tachycardia, and beta blocker will treat that tachycardia or prevent that tachycardia. So they are a good combination with amlodipine. So please remember, beta blocker plus verapamil is avoided and beta blocker plus DHP is suggested or recommended combination. Okay. So that is the beauty of calcium channel blockers and beta blockers. So to summarize, calcium channel blockers are mainly of two types. One is verapamil type, and the other one is dihydropyridine type, the dipines. With DHPs, you want to give beta blocker. That is a recommended combination, and with verapamil, you want to absolutely avoid beta blocker. That will cause cardiac block. So that is what you have to remember. Next question. Anti-anginal drug of choice in a patient with vasospastic angina. Even if you stop the question here, answer remains the same. Vasospastic, also known as variant angina or also known as prinzimetal angina. So one thing that we have to be clear in variant or prinzimetal angina, that one anti-anginal drug is contraindicated, and that is beta blocker. Beta blockers are contraindicated in variant angina. They will worsen they will worsen the vasospasm. So that is totally out. Totally out. Now when it comes to variant angina, please remember this is the order of drug of choice. Calcium channel blockers are considered more effective or better drug than nitrates. Now that brings us to something more basic in nature. When we talk of angina, we have three first line drugs for angina are three: nitrate, beta blocker, and calcium channel blocker. Three first line drugs are there of angina, any kind of angina, variant or non-variant. Out of this, what we are saying in variant angina, one of the first line is contraindicated beta blocker. So what remains? Nitrate and calcium channel blocker, and out of those, this is the order. This is the order. Now, among CCB, which kind of CCBs are preferred for vasospastic? We will have dihydropyridines. That is the dipene type of CCBs, which are more preferred. So I am looking for amlodipine as one of the better drug for vasospastic angina. Dihydropyridine. Now look at the answers, Sunil. I think I have told you. I am not saying nitroglycerin cannot be used. Yes, it can be used. But if you have to choose between CCBs and nitrates in vasospastic angina, the preferred option is CCB. So that is. Now, Vinash, you are saying non-DHP CCB and then saying amlodipine. I think you are confused. CCBs are of two types, DHP and non-DHP. DHPs are dipene, so amlodipine is a DHP. Coming to verapamil, verapamil may be considered, although it is not used because there is a clear-cut mention sinus bradycardia. So verapamil, diltiazem, both are non-DHPs and they both are cardiodepressant. So in the moment you have sinus bradycardia, they are totally out. Even if sinus bradycardia was not there, still DHPs like amlodipine are preferred drug for variant angina. So please remember, vasospastic or variant angina, DHPs over nitrates. That is what is the answer here. Next question. After angina, I have told you several drugs for angina. CCB I have told you, beta blocker and nitrate. Three main drugs, second line drug, ranolazine, trimetazidine, everything I have told you, nicorindil. Now you come to MI, myocardial infarction. So now listen to this very, very carefully. We have a 57-year-old male who presented with chest pain, which settled or it was relieved following aspirin and nitroglycerin sublingually. So pain, it was relieved by aspirin and nitroglycerin. ECG showed a non-ST elevation MI. Okay. On examination, he appeared comfortable and was able to complete sentences. So examination shows comfortable patient sitting or lying down in the bed and he was able to complete sentences. There were no murmur, so arrhythmia maybe have not developed. BP was shown as 180 by 105. Heart rate was shown as 52. Oxygen saturation is given as 97. How would you manage this particular case? So now see, this is a typical management of acute MI. Please see, in acute MI, first thing I will give. Patient comes with acute MI, I will give oxygen. But why do I give oxygen? Oxygen I give if SpO2. If there is hypoxemia, then I will give oxygen. Otherwise, if there is plenty of oxygen in blood, there is no need of oxygen. Oxygen saturation is given as 97%. I don't think oxygen is needed. So this option is gone. This option is gone. Please see, we are dealing with treatment of acute MI Prabhakar. So oxygen, no need, since there is too much oxygen already in blood. If oxygen is less than 9, SpO2 is less than 90%, then we give oxygen. Second, we will give this patient antiplatelet therapy. Antiplatelet therapy, we will give initially aspirin. Aspirin is always given unless contraindicated, and generally we nowadays give clopidogrel also. Dual antiplatelet therapy is what we generally give at least for a year, and immediately we also start. So clopidogrel we can give antiplatelet. Third thing comes is anti-ischemic therapy. Anti-ischemic therapy. Now in anti-ischemic therapy, there are three drugs, 3A. I give sublingual nitroglycerin. I give IV morphine. Now why would I give morphine? Please try to understand, why would anybody be given morphine? Morphine is simply given for analgesia. That is the only reason of giving morphine. But you see, patient is comfortable right now. He is comfortable, he is able to complete sentences, so I do not think that there is any significant pain. So morphine, if there is no analgesia, I would not like to give morphine, and therefore any option which has morphine, I will remove that option also. So option B is also gone. Option B is of no use. Morphine is not given because patient right now is comfortable. Second, I will also give this patient beta blocker. I will also give this patient beta blocker. Beta blocker obviously should be avoided if heart rate is already very low. And this patient has low heart rate already. Heart rate is only 52. If I add beta blocker, heart rate will go very low, maybe 30 or 40. So I will not give beta blocker. So any option which has beta blocker is gone. So option A is gone because it has beta blocker. Option B is gone because beta blocker and morphine. Option D is gone because of oxygen. So I hope now it is clear. How will you treat this patient is via this. Is via option number C. Option number C. And then let's come to the exact treatment of acute MI. Okay, for a more detailed discussion, so that we do not miss out. This is acute treatment of MI. Oxygen, first thing to be given if SpO2 is less than 90. Please remember, if it is more than 90, I don't think there is any benefit of oxygen. It will only increase the cost. Okay, so if there is hypoxemia, give oxygen. Antiplatelet immediately, the moment patient is diagnosed, give him 325 milligram stat. Okay, you may also add another antiplatelet to make it dual plate, but aspirin is essential unless contraindication. Anti-ischemic therapy, nitroglycerin will be given. Morphine, as I told you, mainly to decrease pain, and beta blockers will be given unless there is contraindication like bradycardia or heart block or asthma. Otherwise, you will give. Also start unfractionated heparin. You may also use low molecular weight, and also start any statin. Atorva or Rosuva are the ones which are normally used. Now you see these all things that you have done are not definitive treatment. You have just given right now symptomatic treatment till now. What is the definitive treatment? MI, acute MI is due to coronary block. So definitive treatment is removal of that block. Definitive treatment. Treatment of choice. Best treatment. Any word is used, standard of care, primary percutaneous intervention. If you can do angiography or angioplasty, first we do graphy and then if needed angioplasty or stenting, that is the best. If time to PCI, percutaneous intervention, is less than 2 hours, you go for PCI, and if time to PCI is for more than 2 hours, it will take more than 2 hours to perform stenting, and then you give thrombolytic. So that is how you treat MI. Time to PCI you have to keep in mind. More details will be obviously discussed in medicine. Prabhakar is asking, sir, does morphine cause vasodilation? Second action in MI? Yes, morphine, as I said, it is mentioned under anti-ischemic. So it will cause vasodilation, primarily venodilation, so some reduction of preload and therefore reducing cardiac work also. So it does have, besides pain, some anti-ischemic action also. Okay, that is the treatment of acute MI. Beta blockers avoid if there is heart block. Morphine do not give if there is no pain, and oxygen do not give if there is already too much oxygen available. Next, for the patient in previous MCQ which we have discussed, his chest pain returned after some time with greater intensity, and ECG now showed ST elevation in V2. Earlier it was non-ST, now it has turned into ST elevation. Pain has returned with greater intensity. What would be the best management for this patient now? Tell me now. Neha, do not confuse acute MI with heart failure. Heart failure is separate. Heart failure is not synonymous with acute MI. So please understand, what you are saying is correct, but that is different. So now you see best management is asked, ST elevation is there. There is no doubt, proceed to coronary angiography, that is percutaneous intervention. Whenever best management, definitive management, treatment of choice or acute MI, proceed to coronary angiography. If time to PCI is going to be more than 2 hours, then you will go for thrombolysis. Otherwise, you will not go for thrombolysis. Please understand, thrombolysis will be done time if time to percutaneous intervention, that is angiography, is more than 2 hours. You cannot do angiography. Cath lab is not available. Cardiologist is not available. 2 hours more than it will take to do it. Then you thrombolyze with alteplase. Otherwise, this is the best treatment. Next, a man presents with chest pain. ECG shows ST segment depression in V1 to V4. So we have a case of ST segment depression now. Okay, ST segment depression. So it could be angina, it could be non-ST elevation, acute coronary syndrome. Which of the following should not be given? Not be given. Tell me, ST segment depression is there. Which should not be given? So this is a one-liner MCQ. Please remember, if ST elevation, is absent, ST elevation is not present, then don't use thrombolytics. Simple as that. No benefit has been seen in non-ST elevation MI of thrombolytic. So thrombolytic will never be given if ST elevation is not given. Simple as that. Okay, this is a medicine question. ST elevation nahi hai, thrombolytic nahi dena. Now we have a 59-year-old man presents with left ventricular infarction. So it is MI. He is given all the drugs below. Which drug provides immediate relief but does not reduce risk of sudden death from another MI? So long-term mortality, which drug will not reduce? Which drug will not reduce the risk of death from a subsequent MI? Subsequent MI, which drug will not reduce? So aspirin or antiplatelet? They reduce long-term mortality. Please remember, they reduce. Statins reduce long-term mortality. ACE inhibitors. Please remember, ACE inhibitors have no role in treatment of acute MI, but they are given post MI to reduce the risk of sudden death from subsequent MI. So please remember, ACE inhibitor reduce long-term mortality. They are not used, or they have no definitive place in the treatment of acute MI. Beta blockers obviously reduce long-term mortality or death from next MI. It is the nitroglycerin, nitrate, which provides immediate relief but not a benefit of the long-term mortality. So answer is C. So antiplatelet, statin, ACE inhibitor, beta blocker. These are the drugs the patient will be taking daily. So I hope now it is clear that 1, 2, 3, 5. These are the drugs that a patient will take daily post MI. And 4 is a drug that he will take as and when required, SOS, only when there is pain. So please remember this. Post discharge from MI, patient will take these drugs daily. And 4, he will take only SOS, nitroglycerin. He will take only SOS whenever there is pain, otherwise no. So that brings us to end of this short and sweet session. We have exactly 30 minutes of question. Some time is taken in these initial and later on slides. So I try to cover the most important points in a very short span, and I am very confident that if you attend these sessions that we are having, you will find pharmacology questions from these sessions only and only. So please block your calendars for tomorrow, 10 a.m. in the morning on the Unacademy app. This is a free class. We will do recap of 2020 Pharmacology MCQ. So therefore, if you have not yet downloaded the Unacademy app, please do it right away. Use this code Dr. Arpit Agarwal and you will be able to unlock this free class using this particular code. And please also join me at 10 p.m. after 20 minutes for another episode of Last Minute Revision MCQ, Drugs for Arrhythmia. And you know how important the topic is, drugs for arrhythmia. At 10 p.m. we will start on your favorite Let's Crack NEET PG YouTube channel. So again, to end, if you have not downloaded the Unacademy app, please download the Unacademy Learning app and use the code, as I always say, Dr. Arpit. Use this code, Dr. Arpit Agarwal. It will help you in unlocking the free classes. So that's all in this session. I hope you enjoyed the session. Please do not forget before you leave to hit the like button, to share it with your friends, and also subscribe to the Unacademy NEET PG channel, YouTube channel. And also, if you have not downloaded the Unacademy app, please do it right away. Okay? And please share this, like this, and visit